Hi, I'm Dr. Carlos Brun. Welcome to this video on the subxyphoid window. Why do we use the subxyphoid window, also known as the subcostal window? Well, we use it to assess hemodynamically unstable patients as an alternative view to the apical four-chamber because you're going to essentially have a very similar view from this window. So in code situation during CPR, you can actually place your probe and begin to acquire an image so that during a pulse check you will be able to rapidly assess for the etiology of the hemodynamic instability. This is because you can see certain things. Just like in an apical four-chamber, you can see the right ventricle versus the left ventricle, the right atrium versus the left atrium, the tricuspid valve, the mitral valve, and the pericardial space so that you can possibly diagnose pericardial fluid leading to tamponade physiology. Another special thing about the subcostal or subxyphoid window is that you can focus on the right atrium and then rotate your probe 90 degrees to assess for the IVC or inferior vena cava. And this will allow you, in the context of knowing what your right ventricle looks like versus your left, to make some qualitative assessment of volume status or how dry your patient may be. So the final thing is to acquire these images. So let's get to it. We're going to be performing the subxyphoid window views. Of course, we have our phase array probe here. Notice again that I have marked our indicator notch with orange tape so it's more easily assessed by you on video what direction and orientation the probe is in. So we're going to go ahead and use the subxyphoid window, which is approximately 2 fingers breadth down the midline below the xyphoid. You can always warn your patient that this can be a little uncomfortable. If they need to remove the tension from their abdomen, they can bend their knees. The other place that you're going to go aside from this location is slightly to the right of the midline. As the heart is sitting in the chest in this fashion, you're going to want your beam going towards the left shoulder and your orientation notch will be towards the left flank. So a little bit of gel, might be cold. This is a sterile gel packet, but you do not have to use sterile gel. So we're going to place our probe as mentioned. Notice I have a knife grip as opposed to our normal pencil grip. And my beam would be most likely angled inappropriately, so I'm going to angle it towards the shoulder. We're going to start to see an image. Now notice that the depth is deeper than a peristernal or apical typically, so you increase it to at least 20. Now I'm beginning to see the most superficial portion, or at the top of the screen, I have an acoustic window through the liver. That's why it looks like that. And then we begin to see below that the right ventricle, the most anterior structure of the heart, followed by the left ventricle. On the left-hand side of the screen, we see the atria, right atria, and left atria. This is actually the aortic valve that we see at the base of the septum, ventricular septum, and atrial septum. So what I'm doing when you see the aortic valve is your beam is going to be a little bit too superficial, and you actually have to beam deeper because the aortic valve is a little bit more anterior than the structures what we're looking for. What we're looking for is to get a subxyphoid four-chamber, essentially. So I'm going to actually beam my ultrasound towards that shoulder, and I'm going to tilt the beam down towards the bed, and then I'm going to begin to rotate my indicator notch to open up this alignment of the ventricles. And we're beginning to start to see our tricuspid valve and a very hint of the mitral valve. Now, when you're looking at a four-chamber heart, view of the heart, you want to see both the tricuspid valve and the mitral valve to be able to make any sort of size comparison between the left ventricle and the right ventricle. If you do that, you're in the right alignment to be able to judge the right ventricular size. A normal right ventricle is going to be 2/3 or less the size of the left ventricle. If the right ventricle is the same size as the left ventricle, or a ratio of 1:1, that is severely enlarged, and that's abnormal, very noteworthy. Another thing that you can do from this position is to assess the global motion of the right ventricle, you can see that the tricuspid annulus is moving towards the apex of the right ventricle, and that's normal. You want to see that moving at least 1.5 centimeters, and it's having a very nice excursion. It's moving very well. You also want to see the walls contract. The free wall of the ventricle, or the most superficial wall, is going to be contracting towards the septum, and that's a good sign. Finally, in this point, I can't really see the apex of the right ventricle. But for now, we have a good concept of the left versus right. Again, this is a very rapid view that's useful in during code situations, because you can place your probe during chest compressions, and during pulse checks you have a moment to record this image and make a rapid interpretation and assessment. So, for example, if we were in a code circumstance, we'd also be looking for pleural pericardial effusion, and pericardial effusion would be found between the liver's edge and this bright hyperechoic line at the top, or the pericardium. If there's fluid there, you want to assess for whether the right atrium is collapsing or the right ventricle is collapsing. You'd also be looking to see if the interventricular septum is bowed towards the left ventricle, signifying potential volume or pressure overload of the right ventricle. You can also look at the interatrial septum for bowing towards the left atrium as well, and you can look at the relative sizes of the right and left atrium to assess for how full or how pressure overloaded they may be. Now, if we increase our depth even one more click, sometimes you can see the aorta in this view, not just now, so we'll go back to 20 centimeters. Now, the other thing you can do is actually rotate this probe 90 degrees. If we begin rotating, we're going to start to immediately pick up the aortic valve, and then we have some fallout. So we're going to go back to our 4-chamber view, which we just had. So always go back to the image that you see most clearly. That is your home base for sorting out what adjustments you need to make. And you will adjust based on the ART, angle, alignment, rotation, and tilt. You're going to adjust one thing at a time. So again, let's try to focus on the mitral and tricuspid valves, put them in the center of our screen. By moving our beam or our tail, that will allow us to move the relative position of the heart on our screen. We center those valves, and we begin to rotate counterclockwise 90 degrees. In doing so, we'll begin to get a short axis view, and we start to see the beginning of the aortic annulus, and we start to see at the right atrium an opening at around 9 o'clock. And that's actually where the IVC comes through the liver and ties into the right atrium. And so the other way of picking this up, once you have it by rotation, is to tilt your beam to be in alignment. If the SVC and IVC are in a plane this direction, and my beam is cutting it at an obtuse angle, if I bring my tail up and my beam in alignment to cut it at 90 degrees, then I should clearly see that tube of the IVC. Now granted, I have some fallout, or I have just darkness here, possibly from bowel gas, possibly not. But we begin to see the base of the IVC, and at the 12 o'clock position, right next to the right atrium and IVC junction, is a hepatic vein. That's actually a potential pitfall when people just measure both the hepatic vein and the IVC. But this is the classic position where people will measure the IVC. And what you're looking for to assess volume status partially was first that we have a normal right side appearing right side, because the IVC is a passive tube. If you have an enlarged right ventricle, the IVC diameter or collapsibility may not reflect volume status. So the IVC, to assess for volume status, is not done in isolation. But now that we're able to look at it, what we want to do is essentially measure the diameter of the IVC. And we do this when he's breathing. And you can do this in a mechanically ventilated or spontaneously breathing patient. So our image is not terribly clear. We're going to go back to the subxyphoid, use our normal alignments back to home base. We're going to rotate back through. Excellent. So that was faster this time, but still a similar image. You want to measure the IVC size approximately 2 centimeters from the right atriocaval junction to the IVC. So we're not quite seeing all that. In this case, you could also freeze the image and then do formal measurements with your calipers. For example, if you hit a caliper button, you can move the cursor, select, and then move the other cursor. And you'll notice in the bottom left-hand side of the screen, it gives you an actual assessment. So it's just below 1.7. A normal IVC will have approximately below 1.7 centimeters, and it will have collapsibility of greater than 50%. If you have that, your CVP estimate would be between 0 and 5 millimeters of mercury. Now, if it's 1.7 centimeters and does not have collapsibility, that could be a CVP of approximately 5 to 10 millimeters of mercury. If it's greater than 1.7 and has minimal collapsibility, you can obviously see that the pressures would continue to increase. For a mechanically ventilated patient where the RA pressures and IVC can be transmitted to the IVC, if you have measurements there, it's less specific because of the added pressure from positive pressure. So you don't want to use those same rules of thumb. So this is the basis of the subxyphoid views that we can see in this patient. I think it's time for you to get some practice. Let's summarize what we've just done with the subxyphoid window. You've learned how to acquire the subxyphoid 4-chamber view and then rotate to an IVC or inferior vena cava view for volume assessment in the context of right ventricle and left ventricle function and size. So remember, although we've practiced this well just now, you may not be ready to use this clinically immediately. You need to practice as much as possible and have someone who is skilled in these techniques instruct you on the appropriate acquisition and interpretation of these images. Finally, tips on how to get your best images from the subxyphoid window. Remember, you want to have a knife grip with your hand not over the top like the pencil grip, but in a knife-like grip. That way you don't get in your own way. You want to select a cardiac exam with a depth of approximately 21 centimeters. Remember, the position is a little bit different. You're going to go about 2 centimeters below the xiphoid process and come over to the patient's right. You're going to 2 centimeters as well. And then you're going to have the indicator notch towards the patient's left flank with the beam towards the patient's left shoulder. And then finally, you're going to have to rotate and tilt appropriately. Knowing that, when you're trying to acquire the inferior vena cava image, you're going to focus on the right atrium and then rotate 90 degrees to be able to have the IVC really visible to you. And a pitfall, of course, that can happen is that you may have captured the aorta. And so practice, practice, practice. Nicely done. See you next time.